have Dr. Vishal sir. Can you hear us? Okay, I'll move forward. Doctor, I would like to request Dr. Sujata Ghosh madam to kindly share a few words. She is the governing council member of ISA National, and we are grateful that you are with us today in this webinar. Dr. Sujata Ghosh madam, you can kindly share a few words before we start?
Good evening, President Sir, Dr. Naveen Malhotra, our Secretary, Dr. Vishal Singla, Swati Madam, all the respected colleagues, and my dear postgraduates. It's an absolute pleasure for me to be in this podium today, this online podium, and with the busy schedules of ICU, ward rounds, and whatnot. I think this continuing online education is a pleasure and an advantage for us. And as I always say, let learning continue. Thank you so much.
Thank you so much, ma'am. Before we begin with the first lecture, that is
Dr. Abhijit, I think Vishal sir is online now.
Yeah, Dr. Vishal, can you hear us? Dr. Vishal sir?
I think he is having network problems.
I think so, yeah. Whenever he comes online and he can hear us, I think we'll take it in between the lectures. We'll hear a few lines from him as well.
And I think there is some issue with the network problem. Please go ahead. Best wishes with
the
RSACP webinar, and all the best to the team. And I'm sure the two topics, monitoring and pheochromocytoma, there will be great learning experiences. And I might.
All right. So basically, before we go ahead to the first talk of Dr. Srinjoy on multimodal neuromonitoring, so we have chosen the theme unity in diversity because as we progress in our anesthesia career, the anesthesia specialty is being increasingly fragmented into subspecialties. But that's probably why we have chosen this two polar topics, which are way apart in their clinical spectrum. But still, our main goal is to give safe and thought and precise anesthesia to patients. So as we cater for wide spectrum of patients, I think that's why we have kept the theme like this, unity in diversity, so that we can give diverse topics in a same pool of anesthesiologists. So with this prelude, I would like to hand it over to Dr. Srinjoy. Dr. Srinjoy is the DM Neuroanesthesia resident in AIIMS Kalyani, and he'll be presenting on multimodal neuromonitoring. And I would like to request Dr. Anjum Madam and Dr. Shubhajit Guha to chair the session. So Dr. Srinjoy, please, I'm stop sharing. Please share your presentation.
Okay, sir.
Yeah, make it full screen. Present.
Okay, sir. It's okay.
Yeah, now it's okay. Go. That's it. It's okay.
Okay, sir.
Please start presenting.
So yeah, very good evening to my seniors, my colleagues, and dear esteemed all these faculty members. I'm very thankful to RSACP for giving me this opportunity. And today I am presenting this topic on multimodal neuromonitoring. I am Dr. Srinjoy Varman from AIIMS Kalyani. So why do we need multimodal neuromonitoring? Because traditional bedside neurological evaluation, while they are clinically foundational, but inherently qualitative. And then there is intermittent neuroimaging, which provides valuable structural snapshot, but it fails to capture transient or rapidly evolving physiological crisis. And there is no single monitor which can capture the whole picture. and to prevent secondary brain damage and to identify the specific mechanism of injury from hypoxia, hypotension, hypocapnia, hypercapnia, hypoglycemia, hyperglycemia, anemia, or from underlying seizures. What are the objectives of today's class? Like ICP monitoring, indications of ICP monitoring, waveforms of ICP, invasive versus non-invasive methods, then brain tissue oxygenation, some near-infrared spectroscopy, raw EEG and processed EEG, evoked potentials monitoring, surface electromyography, triggered electromyography, cranial nerve monitoring, and cerebral microdialysis. So we can see this image, that is the summary of the whole multimodal neuro monitoring. At first, we can see the driving pressure. So we can monitor the driving pressure by measuring ICP and CPP. Then we can monitor the blood flow by monitoring transcranial Doppler through measuring the local cerebral blood flow and regional cerebral blood flow. And then we can monitor the oxygenation by three topics. That is the PbTO2, that is the local brain tissue oxygen saturation, SjVO2, that is the global oxygen saturation, and NIRS, that is the near infrared spectroscopy, which measures the regional cerebral regional oxygenation. And then we can measure the microdialysis, cerebral microdialysis. From that, we can measure the lactate pyruvate ratio, glycerol, all this. Then we can measure the electrophysiological functions, that is the EEG, qualitative EEG, quantitative EEG, and evoked potentials. Coming to ICP monitoring. So currently, there is no universally accepted guidelines, but there is a Brain Trauma Foundation guidelines which set out some clear indications for ICP monitoring in traumatic brain injury. So ICP monitoring in trauma, according to Brain Trauma Foundation guidelines, ventricular catheter connected to an external strain gauge is the most accurate method to monitor the ICP. According to level 2 evidence, there are some level 2 evidence and level 3 evidence. Level 2 evidence, that is a moderate quality evidence, and level 3 evidence, that is a low quality evidence. Level 2 evidence says that ICP should be measured in all salvageable patients with a severe traumatic brain injury, that is GCS 3 to 8, and treatment should be initiated with ICP thresholds cut off above 22 millimeter of mercury. And if abnormal CT scan is present, that is abnormal CT scan is defined by hematomas, contusions, swelling, herniation, and level 3 evidence is that severe traumatic brain injury with normal CT scan, but if two or more of the following features are present, that is age more than 40 years and presence of unilateral or bilateral motor posturing. That motor posturing is defined by presence of there's decorticate or decerebrate rigidity, and if the systolic blood pressure is less than 90 millimeter of mercury. So this is the normal ICP waveform. Here we can see the three peaks, that is the P1, P2, and P3. Here is the P1, P2, and P3. Sorry. P1, P2, and P3. P1 is the percussion wave that represents the arterial pulsation. P2 is the tidal wave that represents the intracranial compliance. And P3, that is the dicrotic wave, which represents the aortic valve closure. Some normal values of ICP. In adults, 5 to 15 millimeter of mercury. In children, 3 to 7 millimeter of mercury. In infants, 1.5 to 6 millimeter of mercury. And here we can see that ICP here in the image, we can also see that the ICP waveform is pulsatile in nature. It varies and it correlates with the respiratory and cardiac cycles. With amplitude of the cardiac wave varies between 1 to 4 millimeter of mercury, and amplitude of the respiratory wave varies between 2 to 10 millimeter of mercury. Here we can see the three image where A is normal case scenario, B where the compliance is reduced, and C where the critical compliance is lost. So in A, the waveform is like P1 is more than P2, more than P3, B where the compliance is lost, that is the P2 is more than P1, and C where we can see there is uncal herniation and also more severe edema. So here the P1 and P2 merges. This is a video showing okay, so this is a video showing normal ICP waveform where we can see that P1 is more than P2, and here we can see that yes, here we can see that ICP is 30. So here P2 is more than P1. These are some pathological variations of the ICP waveforms, that is Lundberg waves, known as Lundberg waves commonly, A waves, B waves, and C waves. So A waves, what is A waves? A waves is like highest rise in ICP. ICP rises around 50 to 100 millimeter of mercury, and it passes for 5 to 10 minutes. And it indicates cerebral ischemia and impending brain herniation. Here is the B waves, and here in B waves, ICP elevation is 20 to 30 millimeter of mercury, and it passes for 1 to 2 minutes, and it indicates evolving cerebral injury causing a gradual increase in ICP. This is the C waves. It is a normal physiological phenomena. It is a small, rhythmic, and relatively benign fluctuations in intracranial pressure, and frequencies 4 to 8 waves per minute. These are some ICP monitoring techniques which are divided into invasive and non-invasive techniques. If you see the invasive techniques, that is divided into based on some technological differences and based on location. Based on technological differences, that is external ventricular drainage, that is the gold standard. And there are some microtransducer ICP monitoring devices like Codman strain gauge, Camino's fiber optic device, Spiegelberg's pneumatic system. And based on location, catheter can be placed at intraventricularly, intraparenchymally, at epidural, subdural, or subarachnoid space. Non-invasive techniques available are TCD, that is based on pulsatility index and tympanic membrane displacement, some optic nerve sheath diameter, and we can also measure ONSD from MRI and CT, and there is automated pupillometry available for non-invasive ICP monitoring techniques. Here we can see all the location to place this ICP monitoring techniques. There is the EVD, epidural. Also, it can be placed in epidural place, subdural space, subarachnoid space. This is a diagram of the external ventricular drainage system. Here we can see the black catheter tip. At the tip is in the frontal horn of the lateral ventricle, and then that is connected to a sampling port where we can take out the blood sample, fluid sample, and send for analysis. And here is the transducer. This transducer can be, a transducer is level at the level of tragus, which is a foramen of Monro. So these are all a ventricular access point, which can be used to put the EVD catheter, known as like Kocher's point, Kopman's point, Keen's point, Dandy's point, Frazier's point. But most commonly used is the Kocher's point. That is 1 to 2 centimeter anterior to the coronal suture. So, and this is the microchip transducer setting, which is known as the Codman's strain gauge. Here, the microchip transducer, we can, yep. So when ICP is increased, when ICP is increased, it puts a pressure on the microchip transducer and it bends the transducer. So the change in resistance that is translated into ICP. Here in the left side of the left side of my screen, you can see the Camino fiber optic device, which is a fiber optic device. There are three things that, like sending fiber. One is the sending fiber that sends the lights, and there is the diaphragm which senses the pressure, and there is the receiving fiber. So light passes through that sending fiber and goes to the receiving fiber. But when ICP increases, it puts pressure on this diaphragm, and that change in the intensity of that light is reflected. Change of the intensity of light reflected is converted to an ICP readout. Here we can see the Camino's. Here we can see the Camino's Spiegelberg's pneumatic system. So this is consist of the catheter, a hollow catheter, and elastic air pouch at the tip. So when ICP increases, this puts pressure on this air pouch, and then pouch deforms. So the pressure is transmitted through that air-filled catheter, and transmitted through that air-filled catheter, and this goes to the device which measures the internal pressure. This pressure sensor measures that pressure change, and that is converted into an ICP readout. Here we can see the non-invasive ICP monitoring technique like optic nerve sheath diameter measurement. So we can measure that optic nerve sheath diameter by using MRI and also from USG. We measure this optic nerve sheath diameter exactly 3 millimeter behind that globe, 3 millimeter behind that globe. And here are some normal cutoff, like less than 5 millimeter is normal, 5 to 5.5 millimeter is borderline, and more than 5.5 millimeter is abnormal or elevated ICP. In infants, cutoff is typically more than 4 millimeter, and in children 1 to 13 years, cutoff is typically more than 4.5 millimeter. Here is a video of showing optic nerve sheath diameter. Here you can see that optic nerve disc is elevated in the right eye, and around here you can see that right optic nerve sheath diameter is more than 5 millimeter, which is abnormal. But still, there are some limitations of optic nerve sheath diameter measurement, like it is operator dependent, and it cannot provide continuous monitoring, and it may be affected by some orbital pathology like optic neuritis, orbital tumors, Graves' ophthalmopathy. So coming to my next topic, transcranial Doppler. We can measure the blood flow. We can measure blood flow. We can it does not measure ICP indirectly. It measures the cerebral blood flow velocity. Middle cerebral artery is most commonly used for insonation through the transtemporal window, and two indexes calculated, that is the resistance index and Gosling's pulsatility index, which correlate with ICP. This pulsatility index is calculated from three factors, which is known as peak systolic velocity, end diastolic velocity, and mean flow velocity. This is a relationship between PI and ICP, which shows a positive correlation between ICP and raised ICP and pulsatility index. And estimation of ICP, we can measure the ICP from a formula that is developed by Wakerly et al. That is ICP is more about is equal to 10.93 into PI minus 1.28. But still, there are some limitations also. TCD has some limitations, like it is also operator dependent. It is an indirect measurement. It has some poor acoustic window, and it is affected by some physiological factors like blood pressure, temperature, PaCO2, cardiac output, increased hematocrit, or increased viscosity. Coming to my next topic, there is automated pupillometry. It is a handheld infrared system which automatically tracks and analyzes the pupil dynamics over a 3-second time period. And then from this value, like size of the pupil, percent constriction of the pupil, latency, constriction velocity, and dilation velocity, it calculates the neurological pupil index. So the normal neurological pupil index is value is more than 3.0, which is normal. But if NPI is less than 3, it is a predictor of increased ICP. Coming to the flash evoke potential. So when ICP increases, optic nerve get compressed and there is decreased microvascular perfusion. So if optic nerve dysfunction occurs, there is decreased conduction velocity, and that can be measured from this flash visual evoke potential. So if we see the flash visual evoke potential waveform, there is certain positive and negative waves, and the most important are that N2 and P2. So most reliable if a VP components. So we measure the latency of these two components, and latency increases in these two components, that is at N2 and P2 level. There are some radiological techniques like CT scan and MRI. We can also measure the increased ICP from this CT scan and MRI techniques. In CT scan, we can see the midline shift, basal cistern effacement, ventricular compression, or loss of gray-white differentiation. And from MRI, we can measure the optic nerve sheath diameter also. So here are the two CT findings where you can see that sulcal effacement in the left side here you can see the sulcal effacement, and in the right side here you can see that cistern is normal, and that right side the obliteration of the basal cistern. Coming to cerebral microdialysis, it is an invasive technique that is used in neurocritical care, and it continuous monitoring of cerebral metabolism, and it measures markers like glucose, lactate, pyruvate, glycerol, glutamate. Lactate pyruvate ratio is important. When lactate pyruvate ratio is more than 40, that is suggestive of cerebral ischemia. When glutamate is more, that suggestive of excitotoxicity. This is a common cerebral. This is a cerebral microdialysis catheter. Coming to brain tissue oxygenation. So it measures the partial pressure of oxygen in localized region of brain tissue. But regional brain hypoxia can occur even with normal ICP and CPP. So probe in normal value of PbTO2 is around 25 to 36 millimeter of mercury. If less than 20 millimeter of mercury, it suggests hypoxia. Probe normally is inserted in the white matter of the right frontal lobe through a small bar hole and is fixed with a bolt system. Coming to near infrared spectroscopy. So what is near infrared spectroscopy? NIRS is a non-invasive technique that uses near infrared light to estimate regional cerebral oxygen saturation by detecting changes in oxyhemoglobin and deoxyhemoglobin concentrations in the cerebral tissue. So it emits a near infrared light that is 700 to 1000 nanometer, and there is presence of two photodetectors. That is, one is a shallow detector, and another one is a deep detector. So light is absorbed by this oxyhemoglobin and deoxyhemoglobin, and then there's returns to this shallow detector and deep detector. So from this, it calculates the regional cerebral oxygenation, which reflects arterial, capillary, and venous oxygenation. But venous dominant is more, around 75 to 80% of the signal is venous oxygenation, and normal value is around 60 to 80%. So coming to next topic is my EEG. EEG is the surface recordings of the summation of excitatory and inhibitory postsynaptic potential that is generated by pyramidal cells in the cortical gray matter. So it measures the electrical activity of the brain. And at first, if you see this, these are the EEG electrodes placed over the scalp, and the raw EEG is acquired. And from that raw EEG, Fourier transformation is done, and then there is generation of all this frequency band that is named as alpha, beta, that gamma, delta. So here are the normal EEG waveforms, that is according, and it is divided according to that frequency. It is gamma, beta, alpha, theta, and delta. Gamma is more than 30 Hz, beta is 13 to 30 Hz, alpha is 8 to 13 Hz, and theta 4 to 8, and less than 4 is delta. Here are some EEG waveforms, abnormal EEG waveforms. Here you can see that this is a normal EEG, alpha rhythm, then generalized slowing, which is showing in case of encephalopathy. There are some epileptiform activity, which typically shows some spikes and wave pattern. And here is the burst suppression, where silence then followed by hyperactivity. Coming to my next topic, that is processed EEG. Processed EEG can be captured from first this EEG. This EEG is acquired from the frontal lobe. This is the four electrode. This EEG is acquired from that brain, and then it is amplified. Then this is amplified by amplifier. Then that is filtered. This all these artifacts are filtered. Then this filtered EEG is passes through this analog to digital converter, and then after again this filter, it goes through an algorithm and generates a index number. And we can see the index number in processed EEG monitor. Here are some processed EEG monitors, that is BEAS, entropy, narcotrend, patient state index, DSA, SNAP index, and cerebral state monitor. In BEAS, we can see that here is a number that is generated, that is 49. The normal value is like 40 to 60 for deep general anesthesia. Here we can see that entropy, which is showing RE and AC, that is response entropy and state entropy. RE value is around 0 to 100, but AC is around 0 to 91. Here we can see the narcotrend, where it is showing that E0 and 28, instead of number, narcotrend shows alphabets, that is A to F. D and E indicates that it is general anesthesia under deep general, D indicates under general anesthesia, and E indicates that general anesthesia with deep hypnotic state. Coming to evoke potentials, that is, there are two types of evoke potentials, that is somatosensory evoke potentials and somatosensory. One is somatosensory evoke potentials, and another is motor evoke potential. So first, somatosensory evoked potentials. It mainly monitors the dorsal column pathway. So at first, we give stimulus to the peripheral mixed nerves. Normally, in case of upper limbs, median and ulnar nerve. In case of lower limbs, DBL and peroneal nerve. After that stimulation, there are two types of response occurred. That is, one is orthodromic, that is, there is a local twitch, muscle twitch, and there is antidromic, that is a it passes through that neural tract and goes to the dorsal column. And we record this evoke potential at different locations like ARPS points at spinal cord, at scalp level. So what is the pathway, SSCP pathway? So at first receptors, then it passes through the peripheral nerves and goes to the dorsal on ipsilateral, and then it passes to the ipsilateral dorsal column, which ascends to the medulla. After it is reaching to the medulla, it crosses contralaterally and enters the medial lemniscus pathway, and then it goes to the thalamus, to the VPL nucleus of the thalamus, and then it enters to the internal capsule, and then it goes to the somatosensory cortex. This is the normal SSCP waveform. In my left side, here is a SSCP waveform from the median nerve, and here is a SSCP waveform right side, SSCP waveform generated from the lower limb. So SSCP waveform has three parts. That is, the one is the latency, one is the amplitude, and another one is the orientation. So this is the first is the latency. That is, latency is the time lag to generate this waveform, and this one is the amplitude of this waveform. And orientation, normally one positive and negative. So this positive is demarcated as N, and negative is demarcated as P. And this 20 and 24, these values are indicative of time lag. That is, after stimulus, it 24 millisecond after that stimulus, there is this generation of this waveform. So some anesthetic considerations for SSCP monitoring. Avoid any bolus dose, but preferably use continuous infusion of propofol-based TIVA preferably. Dexmedetomidine can be used, opioids can be used, but avoid nitrous. Maintain high normothermia, prevent any kind of hypotension, hypoxia, anemia, and electrolyte abnormalities. Here in SSCP, neuromuscular blockade is preferred because it is used to reduce the EMG interference. Here are some uses of SSCP. SSCP can be used in spinal tumors, intramedullary tumors, canal stenosis, in case of scoliosis, to monitor the cortical ischemia. Next, coming to the motor evoked potentials. So at first, here the cortical stimulation is given through the transcranial transcranial electrodes. Then it passes through that cortex, spinal cord, and it mainly monitors the corticospinal tract, and it mainly monitors the corticospinal tract integrity. So we can see the spinal response by D waves, measuring the D waves and I waves. This is not normally done. Normally, we see the muscle response by CMAP, which is the compound muscle action potential. So we put uh, dual needle electrodes in that target muscle, and we see the compound muscle action potential. Some anesthetic considerations for MEP monitoring. Again, same that preferred TIVA is preferred with propofol infusion and opioid infusion, and avoid any kind of deep inhalational anesthesia because it will block the synaptic transmission. Also avoid nitrous and avoid neuromuscular blockade. Use only for intubation if necessary. And all again, there's maintain that stable physiology like normoxia, normocapnia, normothermia, adequate blood pressure should be maintained, hemoglobin should be maintained. Here are some uses of MEP monitoring, like it monitors the corticospinal tract integrity, and it detects the impending motor deficit. Coming to electromyography. So what is the main purpose of monitoring is that it detects in surface. There are two types of electromyography. That is, one is the surface electromyography and one is the triggered electromyography. Surface electromyography monitors the spontaneous muscle activity, but trigger electromyography monitors the evoked CMAP, that is a compound muscle action potential response. So main purpose of monitoring surface EMG is that it detects the nerve or muscle irritation or injury, and triggered EMG, it tests the functional integrity of the nerve or nerve root. So it can be both can be used in spine surgery and cranial surgery. So coming to auditory evoked potential, hearing is the last ability to be lost before unconsciousness and fast to be restored upon emergence. Brainstem auditory, three types of auditory evoked potentials can be measured. That is the brainstem auditory evoked potential, middle latency auditory evoked potentials, and long latency evoked auditory evoked potential. Middle latency auditory evoked potentials is recorded because the brainstem auditory and long latency are more resistant to the effects of the anesthetic drugs. Coming to some cranial nerve monitoring indications, we can monitor some cranial nerves normally in brainstem and cerebellopontine angle surgeries. Normally, the seventh facial nerve is monitored by recorded CMAP, compound muscle action potential. So, principle is that we monitor the motor function of that cranial nerves by direct electrical stimulation at the surgical site. Normally, bipolar probe is used and needle electrodes placed in target muscle. We record the compound muscle action potential. For seventh nerve, normally we monitor the seventh nerve in case of CP, cerebellopontine angle surgery, and we monitor the orbiculus oculi, oris, frontalis, and mentalis. So after all this discussion, so what are the some take-home messages? So that no single monitor can see the whole picture. So multimodal monitoring is required that integrates the driving pressure, oxygenation, metabolism, and electrophysiological data. ICP monitoring remains the cornerstone. EVD is still the gold standard. Non-invasive monitors like options, there are like extend monitoring beyond the ICU like TCD, ONSD, and automated pupillometry are useful screening tools, but each has real limitations and it cannot replace the invasive gold standard monitoring. Normal ICP does not mean normal ICP does not mean a healthy brain. PbTO2 and cerebral microdialysis can reveal regional hypoxia and metabolic crisis even when pressure looks fine. EEG and evoked potentials add the functional dimension, and use of PIVA, avoiding nitrous and maintaining stable physiology, directly shapes monitor and validity for evoked potential monitoring. So the future is integration and combining all this modality to provide a safe and neuroprotective anesthesia care. Here are some of my references, and thank you, everyone.
Okay, thank you, Srinjoy. Okay, if you can please stop sharing.
Okay, sir.
Yeah.
Yes.
Thank you so much, Srinjoy. And now I would like to request our respective chairpersons, Dr. Anjum Madam and Dr. Shubhajit Guha, to kindly share a few expert comments and clinical pearls. Anjum ma'am first. Please, ma'am, you can share some clinical pearls and expert comments.
So first of all, Stranger, it was an excellent overview of multimodal neuromonitoring.
Thank you.
In the audience we have many postgraduates. So I just want to add on something that cerebral physiology in case of an injured brain is very complex and dynamic.
Yes.
Also, that brain is a highly metabolic organ. It needs a constant supply of substrate in the form of oxygen and glucose. And whenever an injury has occurred, the core rationale is to prevent secondary brain injury.
Yeah.
And as has been very rightly stressed by you, that if we rely only on the clinical assessment, it is actually a delayed assessment. By that time, the crisis and the catastrophe has already happened.
Okay.
And it is because very complex. After the brain injury, the physiology alters so much and it is so heterogeneous in every part of the brain that we just cannot rely on the normal invasive monitors which we use, like invasive arterial pressure monitoring, just to maintain the mean arterial pressure. Or we cannot rely only on a single monitor like that. If we can use only the intracranial pressure monitoring, it will be insufficient.
Yes.
Therefore, needs a more comprehensive approach, which is in the form of the multimodal monitoring.
Modal neuromonitoring.
And the multimodal monitoring is actually, it goes so well with the theme of today's webinar, unity in diversity. So when we are using more number of neuromonitoring techniques and we interpret the overall result, then we can have a more comprehensive picture of an individualized and targeted management of the brain. So that's all I have to say. Dr.
Thank you, ma'am.
Thank you, ma'am. Over to Dr. Shubhajit Guha, please.
Srinjoy, excellent
Yes,
presentation,
sir.
very good presentation.
Thank you,
So
sir.
what madam has just said, that primary injury has already occurred.
Yes.
So the main thing is of neuromonitoring is to prevent the secondary
Prevent
brain
the secondary.
right?
Yes.
And to prevent the secondary brain damage, the monitoring starts from your clinical monitoring. Okay. So
Okay.
we have to always remember regarding our Glasgow Coma score, the 4 score, and another scoring system has been introduced in 2018, that is GCSP. Okay.
Please.
So P stands for pupillary reactivity scoring.
Reactivity.
Okay.
Yes,
So
sir.
there are 3 scoring: 0, 1, 2. 0 means when both the pupils are reacting, 1 means only one reacting, and 2 means none of them are reacting. Okay. And another thing I want to mention, that every monitoring has got its own fallacies. Okay,
Yes,
just
sir.
like when you are you introducing inserting an intraparenchymal ICP monitor. Okay, either Codman or Camino. So there is a term which is known as zero drift. That is,
Okay.
whenever you are putting, before putting the transducer, you have to zero it in the atmosphere. Usually we put the catheter inside the water, okay, to zero it.
Okay.
Once you put it inside, then the problem is that you cannot take it out and zero it again. So many a times what happens is the intraparenchymal catheter either gives a under reading or a over reading of the ICP monitoring. Okay. And another third thing I want to mention, that we have to include the measurement of the regional cerebral blood flow also. Okay.
Okay.
By thermodilution flowmetry. Okay, we do thermodilution flowmetry. There what we do actually, we do a bar hole, we put 2 micro catheter inside. Okay, one is active, another is passive. So it actually, the basic concept is that the blood flow actually takes away the temperature. It drifts away the temperature. So
Okay, sir.
if your cerebral blood flow is less, then your active catheter will be more heated. And if the cerebral blood flow is more, then the active catheter will be less heated. Okay. So I think that will complete everything.
Okay,
Thank
sir.
you so
Thank
much.
you, sir. Thank you, sir.
Okay.
Thank you, Dr. Shubhajit. And any respected seniors who are present in this webinar wants to share a few insight on this topic, please feel free to do it. Else we'll move to the next topic. All right. So in that case, let's move to the next topic, and rightly mentioned by Anju ma'am that that's how we have kept this theme of this topic, that although they represent different ends of our specialty, but the purpose is same, to deliver safe and precise anesthesia. So for the next talk, we have Dr. Anuja from AIMS Kalyani, who will be presenting on the current practices of anesthetic management of pheochromocytoma. And to chair the session, we have once again Dr. Palash Kumar, consultant anesthesiologist from Woodland Hospital, Kolkata. Welcome, sir. And next chairperson, we have Dr. Unnati Asthana, additional professor from the Department of Anesthesiology, AIMS Kalyani. And I welcome you, madam, on behalf of RSACP and as the webinar coordinator. And with both of your permission, I would like to ask Anuja to kindly start. Those whoever joined, please. Yeah. Right. Palash, we are starting with the presentation.
Yeah, please start. Do you have the ability to mute others' microphones? Then you can do that, I guess.
Yeah, I'm doing it. Yeah. Please present your screen. Yeah.
So I'm starting.
Yeah. Please
Good
start.
evening. Good evening, everyone, respected seniors and my colleagues. First of all, I would like to express my gratitude to RSACP for giving me the opportunity. Now, without any further delay, I would like to proceed with my topic, which is current practices in anesthetic management of pheochromocytoma. So, what are pheochromocytoma? So these are this name comes from a dusky brown colored cell. So when during staining, these cells turn brown. So this name comes from there. So these are catecholamine secreting tumors of chromaffin cell, usually derived from adrenal medulla, but they may also develop from chromaffin cells in other area, which are known as extraadrenal pheochromocytoma. So the objectives will be discussing the pathophysiology, clinical presentation, diagnostic approach, what are the anesthetic concerns, preoperative assessment and optimization, plan of anesthesia and analgesia, and lastly, postoperative management. So coming to the epidemiology, so these are rare tumors with prevalence of around 0.1 to 1% in hypertensive patient and usually diagnosed in 4th to 5th decade. There is no clear sex predilection. 80 to 85% of are from adrenal origin and around 15 to 20% are extra-adrenal, which are known as paraganglioma. In 25% of pheochromocytoma, germline pathogenic variation has been seen, and approx 40% of the paragangliomas, germline variants have been seen. So, in recent 2024 literature update, it shows high hereditary burden because of the increasing incidence of improved detection, incidental imaging, and genetic screening, and it also focuses on genetic screening in case of known pheochromocytoma case and in history of pheochromocytoma in family. And also the traditional rule of 10, which was earlier used, is no longer an adequate description. Now we'll discuss a few things about the physiology of catecholamines. So catecholamines acts on adrenergic receptors, which are mainly alpha and beta receptors. So alpha, we have alpha 1 and alpha 2. So alpha 1, we have these receptors are present in vascular smooth muscles and responsible for vasoconstriction, which leads to increased systemic vascular resistance and increase in the pressure, blood pressure. And these are mainly noradrenaline action predominates at the adrenaline action. Next is alpha 2 receptors, which are autoreceptor present in the presynaptic nerve endings. And these decreases norepinephrine release via the negative feedback. Next, we'll move to beta receptors. So beta, we have three receptors. Beta 1 mainly are present in heart, JG cells of the kidney, and these have both adrenaline and non-adrenaline action. And these have positive chronotropy, inotropy, and dromotropy. And it also increases renin secretion. Next, we have beta 2, which is present in vascular smooth muscle of skeletal muscles, coronary arteries, hepatic and renal system. So these are responsible for vasodilatation, and here adrenaline action predominates than non-adrenaline. Next is beta 3, which is mainly present in adipose tissue, and it plays an important role in non-shivering thermogenesis, which is seen in brown fat. A few rare tumors have dopamine receptors also. So these are dopamine A1 and dopamine A2 receptors. Now coming to the pathophysiology. So mainly these catecholamines are formed from tyrosine. Tyrosine forms dopa, then from dopamine, norepinephrine and epinephrine are formed. So pheochromocytoma, chromaffin cells secretes excess and episodic release of catecholamines. So there is excessive release of catecholamines. So the effects are mainly in norepinephrine predominating effect, we will see sustained or paroxysmal increase in systolic and diastolic BP, and there will be reflex bradycardia. And in case of adrenaline predominating tumors, there will be increased systolic blood pressure, decreased diastolic blood pressure, and tachycardia. So relative effect of catecholamine can be described as in alpha receptor, mainly there is vasoconstriction because of the noradrenaline predominance, and in beta receptors which are present in heart and beta 2 which is responsible for vasodilatation, adrenaline action predominates. Next, mainly large tumors, they secrete more metabolites, and small tumors, they are mainly secreting more catecholamines. And in case of familial pheo, adrenaline predominates than noradrenaline. So with what clinical feature patients come? So there is classical triad of headache, sweating and palpitation. And also we have 5 P's. The next 6 P was added later, which can be represented as pressure, which will show as hypertension in patients, pain, which will the patient will come with headache, perspiration with increased sweating, palpitation when the patient is aware of his or her heartbeat, then pallor and paroxysmal spells, which are episodic symptoms seen in patients. The other features are in gastrointestinal nausea, vomiting, abdominal pain. There can be severe constipation. In central nervous system, cerebrovascular events due to increased coagulation. And also there can be anxiety and tremors. In cardiovascular system, there can be angina or myocardial ischemia or infarction with even normal coronaries. There can be cardiomyopathy, which can be both dilated or hypertrophic cardiomyopathy, congestive heart failure, and also cardiac arrhythmias and conduction defect. In hematological system, there is thromboembolism risk increase and also deep vein thrombosis. Now, how we will approach with the diagnosis of pheochromocytoma? So, biochemical testing confirms excess catecholamine production, and these are the most sensitive tests. So, mainly plasma-free metanephrine are the most sensitive tests. Earlier, plasma or urinary catecholamines was used, but it is least sensitive. So, when the plasma-free normetanephrine is more than 400 picogram per ml and metanephrine is more than 220 picogram per ml, this is diagnostic of pheochromocytoma. And if it is less than 112 and metanephrine less than 61, it excludes the diagnosis of pheochromocytoma. So whenever we are taking the blood sample, so ideally the sample should be taken after making the patient supine, and we will wait for 30 minutes after that, then only we will take the sample. So this reduces the error. Next, for anatomical localization, this identifies mainly the site, size, and local extent. It is essential for the plan of the surgery. We use contrast enhanced CT and MRI where in children and where CT is contraindicated. For functional imaging, which is important for extraadrenal multifocal or malignant disease, and also in case of recurrence or when the CT or MRI is inconclusive, there is MIBG scintigraphy, gallium dotatate PET scan, and FDG PET scan. Recent updates have given emphasis on genetic testing, indicated in all patients, especially less than 45 years, bilateral or multifocal, or with familial history of pheochromocytoma. It helps in diagnosis, prognosis, and also family screening. The data shows up to 35% of the pheochromocytoma may be associated with germline mutations, and genetic testing should be considered for all the diagnosed patients. Now, what are the preoperative anesthetic concerns which we can see? So first is hypertensive crisis. So patient can present with uncontrolled hypertension or hypertensive urgency or emergency. There can be arrhythmia, which can be tachyarrhythmia or bradyarrhythmia due to excess catecholamine synthesis. And also there is a risk of conduction disturbances also. And these patients are in a continuous vasoconstricted state due to decreased ECF volume, and there is a risk of severe post-resection hypotension. And these patients require adequate preoperative volume expansion before we are taking this patient for surgery. And there are also metabolic disturbances present like hyperglycemia preoperatively due to catecholamines, and postoperatively there is hypoglycemia after the tumor is removed due to rebound increase in insulin. And also catecholamine induced cardiomyopathy can be seen. There is decreased myocardial function, ischemia, pulmonary edema, and heart failure. And also there is risk of myocardial infarction even with normal coronaries. Organ dysfunction in form of cerebrovascular events, stroke, intracranial hemorrhage, renal dysfunction, this can be seen. Now, how we will optimize this patient? First of all, we will go with the PAC where we will take the detailed history of the patient. Detailed examination should be performed where important part is to measure BP both in supine and sitting position and adequate preoperative optimization. We should do counseling of the patient and educate the patient. We should tell the patient about to avoid sudden posture changes and also explain the palpitation and orthostatic hypotension and importance of adherence to the medication. And we will also tell the patient about the perioperative BP swings and need for ICU or HDU monitoring postoperatively. We will well inform the risk consent to the patient, high risk consent for both surgery and anesthesia, and we should take informed written consent. Next, most pheochromocytoma, as we have discussed, secrete predominantly norepinephrine, and medical therapy depends on alpha blockade, mainly to reduce low blood pressure, increase the intravascular volume, prevent paroxysmal hypertensive episodes, allow the resensitization of adrenergic receptor, and decrease myocardial dysfunction. So, in the earlier Roizen criteria was used, which is historical, and it should not be used as a sole endpoint of the optimization. Earlier in Roizen criteria, the BP less than 165 by 90 mm Hg was targeted as the preoperative blood pressure control, but recent 2014 Endocrine Society clinical practice guideline have set the BP pressure control of less than 130 by 80 millimeter of mercury while sitting, and systolic blood pressure more than 90 millimeter of mercury when standing as optimization criteria. And target heart rate 60 to 70 beats per minute while sitting and 70 to 80 beats per minute when standing. So current assessment includes individualized BP heart rate target, adequate beta blockade, alpha blockade, and euvolemia, as well as in the patients with also we will see cardiovascular status. Next, alpha blockade have to be done first. So we are using selective alpha blocker, prazosin, in the dose of 2 to 5 mg BD. After the alpha blockade is achieved, mainly current guideline endorse on optimal duration of around 7 and 14 days preoperatively. Beta blockers we will start. Metoprolol is a choice, and 25 to 100 milligram BD can be used. Calcium channel blocker can also be added, diltiazem 92 up to 360 milligram per day. Now these patients have chronic hypertension, or there can be hypertensive crisis also. So these patients can have hypertension mediated organ damage. So we should go for screening for this also. So there can be left ventricular hypertrophy, cardiomyopathy, ischemia, arrhythmia, renal dysfunction, and cerebrovascular disease. So we should look for in ECG for LVH, SCT changes, any arrhythmia is present or not, and echo when cardiac symptoms is there, and abnormal ECG, or in case of long standing or severe hypertension, or if we are suspecting cardiomyopathy. Renal function electrolytes also we have to see, and also we can consider troponin or BNP and coronary evaluation when it is clinically indicated. Next important part is thromboprophylaxis due to catecholamine induced hypercoagulable state. So we can go for mechanical prophylaxis from induction in the form of graduated compression stockings, and pharmacological prophylaxis can be started 12 to 24 hours post-operative as per the discussion with the surgical team. So, and if the patient is already receiving any kind of pharmacological prophylaxis like enoxaparin, we have to document the indication and dose and coordinate the interruption or resumption with the surgery and regional anesthesia plan, which we are planning. Next important thing is volume repletion and hematocrit reduction. Then we have to follow the ERAS protocol for these patients also, and we have to start incentive spirometry in preoperative period only. Next, what is the plan of anesthesia for the patient? So we will go for endotracheal intubation with controlled mechanical ventilation with thoracic epidural in case of open approach, and QL block or ESP or paravertebral in case of laparoscopic or robotic approach. So in pre-induction, during pre-induction, so we will confirm the alpha and beta blockade, whether the patient is taking medication or not. So we'll take arterial line before induction. We have to secure 2 large bore IV cannulas and central venous access. And vasodilators, short-acting beta blockers, and vasopressors should be prepared and immediately available when needed. Blood products availability should be there according to the tumor size and the operative plan. So infusion pumps, we have to prepare before the induction. So these are the infusion pumps which we need: sodium nitroprusside, esmolol, phenylephrine, magnesium sulfate, dexmedetomidine, and lignofen. So this we have to prepare beforehand. Now coming to intraoperative monitoring, standard ASA monitors we have to use. Along with that, arterial line or cardiac output monitoring with flow track or EV1000 if needed. Neuromuscular monitoring is must. Depth of anesthesia monitoring, central venous catheter, in strict input-output monitoring, then arterial blood gas analysis, blood glucose monitoring, And if the patient is known case of cardiomyopathy or coronary artery disease, then we can also go with transesophageal echocardiography. Now, during induction, it should be smooth with minimal sympathetic stimulation. Magnesium 30 milligram per kg can be used over 10 to 15 minutes, and we can also add dexmedetomidine 0.2 to 0.7 mics per kg, and we can titrate according to the response of the patient. Relatively, we will prefer opioid heavy induction with fentanyl 3 to 5 mics per kg IV, propofol 1 to 2.5 mg per kg IV, or etomidate if the patient is having ischemic heart disease or cardiomyopathy. To suppress the laryngoscopic response, we can use lignocaine 1 to 1.5 mg per kg IV or esmolol 0.5 mg per kg. And the laryngoscopy should be smooth and quick. Muscle relaxant rocuronium 0.6 to 1 milligram per kg, and inhalational agent preferred is sevoflurane. Now, coming to what are the intraoperative concerns which we can face, mainly the anesthesia management focuses on hemodynamic control and good communication among the members of the perioperative team. So, firstly, during intubation and induction, we will expect sympathetic stimulation, which is marked. There is increased BP, increased heart rate. We can expect increased catecholamine surge during pneumoperitoneum creation, and also when there is surgical manipulation of tumor, and also there is fluid shift. So there is risk of hypovolemia during manipulation and vasodilatation after the tumor is removed. And monitoring and communication is very important, as in this pheochromocytoma cases, team communication is very essential. And also there is risk of blood loss, so we will watch carefully blood loss. And also during the ligation of adrenal vein, and as soon as the tumor is removed, there is sudden fall in catecholamines, so there is risk of profound hypotension. There is risk of cardiac arrhythmias due to catecholamine surges, and there can be drug interaction with certain drugs which we are using, so like ketamine, pancuronium. So this we should avoid as much as possible. So intraoperative, we can see catecholamine surge during positioning when the surgeon is creating pneumoperitoneum and during trocar insertion, and when there is direct manipulation of tumor. This leads to massive catecholamine release, severe hypertension, and arrhythmia. Next, when the adrenal vein is ligated, there is abrupt fall in catecholamines and decreased systemic vascular resistance and vasodilatation, which will present as profound hypotension, bradycardia. And after the tumor removal, continuing instability may occur, and patient needs continuous and vigilant monitoring. And hemostasis finally have to check for the bleeding and stability before the closure. Now, intraoperative, these things can be handled by, like when there is tumor handling or manipulation, we can use sodium nitroprusside in the dose of 0.2 to 10 mics per kg per minute, or nitroglycerin 0.5 to 5 microgram per kg per minute. And the dose of sodium nitroprusside should not exceed 10 mics per kg per minute. If there is arrhythmia, so we can use esmolol 0.5 mg per kg bolus. We can use lignocaine or magnesium sulfate also. So when the surgeon is ligating the vein, or when the tumor is removed, there is severe hypotension due to the loss of catecholamine. So fluid, we should give rapid crystalloid or colloid bolus, norepinephrine in the dose of 0.05 to 0.5 mics per kg per minute. Vasopressin, we can add phenylephrine, and adrenaline. Rarely it is used when if the patient is not responding to norepinephrine and vasopressin. In the post-operative period, there is chance of hypotension and hypoglycemia. So we should continue IV fluid. We should monitor glucose hourly, and dextrose can be given if there is hypoglycemia. Now coming to pain management of this patient. So we will go with multimodal analgesia. Paracetamol 1 gram IV 6 to 8 hourly can be given. And NSAIDs or COX-2 inhibitor can be added. If opioid can be added for rescue, fentanyl or morphine titrated according to effect. And if the patient is having significant postoperative pain, we can go with patient control analgesia also. Regional anesthesia, in case of laparoscopic or robotic adrenalectomy, we will give USG guided QL block or electrospinal plane block or paravertebral block. We can also use port site infiltration or intraperitoneal instillation. And if it is open adrenalectomy, then we can go for thoracic epidural. Now we'll discuss some things about surgical approaches. There are different surgical approaches. laparoscopic adenectomy, robotic adenectomy, retroperitoneoscopic adenectomy, open adenectomy, and partial or cortical sparing approach. So this depends on the tumor size, and according to the surgeon preference. Now, post-operative concerns. In post-operative period, there can be profound hypotension, mostly due to withdrawal effect of the catecholamine, vasodilatation, and residual alpha blockade. Hypoglycemia because of decreased gluconeogenesis and glycogenolysis, and persistent hyperinsulinemia. Arrhythmia may occur in immediate post-operative period. Pulmonary complication like pulmonary edema, atelectasis, and aspiration risk, and adrenal insufficiency if the bilateral adenectomy is performed. Pain or sympathetic stimulation, if there is inadequate analgesia, it may precipitate hypertensive episodes. So when we will extubate the patient, so if the patient is awake, following commands, hemodynamically stable, adequate neuromuscular recovery is there, along with low dose stable vasopressor support, so we can plan for extubation. The patient may need ICU or SDU support because we need constant monitoring in the post-operative period, and we should watch for hypotension. Any case of persistent or recurrent hypertension in the post-operative period indicates incomplete resection or extraadrenal disease. We can also see, we have to look for arrhythmias and hypoglycemia, hourly have to monitor. Oxygen supplementation can be given if required. So to conclude, preoperative optimization is the cornerstone to a good perioperative outcome. Never establish beta blockade before alpha blockade. We have to think about the catecholamine surge and its effects, and we have to anticipate the hemodynamic switch, and we have to be prepared, which can happen during tumor removal, abrupt catecholamine withdrawal, and there can be also profound hypotension. So the postoperative period is not over even after the removal of the tumor. There can be hypotension, hypoglycemia, arrhythmia, pulmonary edema, and adrenal insufficiency. And most important thing in pheochromocytoma surgery is closed loop communication between the perioperative team which is there in the OT. And these are my references which I have used. Thank you.
Thank you, Anuja. Can you please stop sharing?
Yes.
All right, nicely presented, Anuja. Now I would like to request our respected chairpersons to share some clinical pearls with the attendees. To begin with, I would like to request Dr. Palasa to kindly say a few expert comments, please.
Well, thank you. This has been a really nice discussion, Anuja. It's a difficult topic. You have comprehensively covered it. This is one of the cases where hemodynamics change very rapidly. So as we have mentioned, our preparation is of paramount importance. So the major thing that minimizes the hemodynamic swing is intravascular volume. Good intravascular volume, both during the pre-op preparation and during the intra-op management as well. So you must tell the patients to drink extra water and take a little bit of extra salt, maybe 2-3 grams a day. After a few days, the alpha blockade is started. Now, it is my personal experience is that the history of the patients when they say that they drink enough water, this is highly unreliable. You have got no clue exactly how much they're drinking. So you have to exactly give them a measure, like you drink 2 1-liter bottles or 3 1-liter bottles, whatever. So that you can, like reliably predict a fluid volume increase, and you can, as you have mentioned, there is an hematocrit drop. If there is intravascular fluid expansion, another measure, though not as precise as hematocrit, is body weight. Patients usually will gain about 1 or 2 kilograms of weight, which is overall fluid in the body, not specific to intravascular volume, which hematocrit tells us. And in the intraoperative period, the fluid administration, as long as you have not ligated the vein, should be minimal, just to the replacement rates. And after that, we have to go in rapidly and infuse about a liter or so that the post-ligation drop is minimized. And if we can do that, especially with present day, the endocrinologists are quite particular about preparing the patients. And if we got a couple of weeks before preparation, the drop is not as catastrophic as you would imagine. Now, another thankful thing that is happening is that the surgeries are happening laparoscopically. And in open surgery days, thoracic epidural can be pretty risky, because even in normal patients with thoracic epidural, the blood pressure drop can be pretty high. So if you are having a patient who is being operated in open surgery and you want to be particular about pain relief and you put in a thoracic epidural, do not start it till you have stabilized the patient post resection of the gland. Your NORAD levels have gone down. You're confident that the patient is not going to, the BP is not going to fall too much because of the vasodilatation caused by the thoracic epidural. So build it up rapidly. And another thing that you can use nowadays, especially for the induction during to reduce the sympathetic stimulation during induction and laryngoscopy, is a remifentanil infusion. It allows you very fast titration, but then I understand that it may not be available everywhere. So it may not be, but I expect it to be available at most places pretty rapidly. And I again congratulate you. You've covered it really well.
Thank you, sir.
Thank you, Palash. Sir, now I would request Dr. Unnati Madam to kindly say her expert comments.
Excellent presentation, Anuja. You gave a very comprehensive and detailed presentation to approach a patient of pheochromocytoma. I agree with Dr. Palash, what he said, that volume repletion is one of our major concerns in the perioperative period. So as sir said, that you start the oral intake, you ask them to start drinking more water, you look for weight gain, you look for the fall in hematocrit. Apart from that, you add extra salt. So, but these patients are usually admitted 2 days prior to the surgery, or maybe even more, depending upon the patient and surgical preference. So these patients are started on IV fluids as well. So an IV fluid therapy is something which can be recommended in the preoperative period as well. Pheochromocytoma, we heard from our PG days, is perhaps, the Formula One of anesthesia. It's got the high speed, it's got the high stakes, and there are rapid turns, unpredictable turns, and sudden crashes. And there is no room for any error. What happens in pheochromocytoma? So if you have attended a case of pheochromocytoma, we have a lot of sets of infusion pumps, which you have rightly talked about. Before, one side, what we keep is before induction, before the ligation, and the other side is once the ligation is done and we are anticipating a sudden drop. So I think just to summarize, the key is anticipation, knowing where the corners are, and have a good multidisciplinary team, just like the pit crew we have, which involves the cardiologist, the endocrinologist, the urologist, so that we can optimize the patient maximally before taking up a patient for pheochromocytoma, so that there are no catastrophes. And thankfully, to the recent advances in surgery where robotics has taken charge, and laparoscopy, that too the retroperitoneal approach to laparoscopy, the results of adrenalectomy, whether it's unilateral or bilateral, they have become way better than what they were when we were PGs. That's it. Thank you.
I'd like to just add one thing about the vasoactive drugs. So this is not specific to pheochromocytoma. In any case where you are expecting to use a vasoactive drug, so there are basically two ways in which we use it. One, we piggyback it on an infusion, or we have a dedicated line for it. Now, especially in a scenario like pheochromocytoma, I would like to prime my lines fully, because let's say you are using a 3-lumen line and you have kept the dilators on one side and have kept the constrictors on one side, and the total volume is going to be small. It's going to be say 0.2 or 0.3 milliliter. But in a time of crisis, if that thing is not filled, it would feel like it's an eternity that the drug is not going. So make sure that you have pre-filled your thing and there is no space which needs to be filled up when you are starting your rhinotop. This is not specific to pheochromocytoma. but everywhere where you are using an inotrope. And be sure to flush those lines, draw the blood and discard it and flush it after you have disconnected the inotropes. That's a mistake that happens in the ICU. You send the patient to the ICU, that line is full of NORAD, and somebody starts a fluid on that line. So unless it is clearly you have disconnected an inotrope or a dilator, you must withdraw blood and flush it with whatever, NS or something, so that none of that vasoactive drugs remains in that line.
All right, thank you, sir. For both the chairpersons, I would like to have two questions. One is, what would be your advanced monitoring choices and vascular line choices? And the second would be the what regional anesthesia for robotic or let's say laparoscopic atherectomies you would prefer?
Sir, in case of if we are going for laparoscopic surgery, so we can go for QL block, or we can use paravertebral ESP, that whatever we are comfortable with. But mainly we are using QL and ESP also.
Okay,
And
So
we
I
can
think the
also
choice
go
of
for port site infiltration also.
the choice for regional anesthesia or epidural, I think it totally depends upon the surgical technique, the tumor size, and whether there is any local invasion. What is going to be the how will you post-operatively manage? So I think open adrenalectomies, we go for epidural, which can be continued post-operatively as well, and the robotic or laparoscopic, we are going for regional blocks. Like she said, we would prefer the QL block or the ESP. That would be it. Yes. Also, I would like to add that now, what was the first question you said? You had asked,
About the
Dr. Abhishek?
advanced monitoring and vascular
Yes.
lines.
So there is something, Dr. Anuja, I would like to add. You said that arterial line may be added if needed. So I would correct you here. It is the gold standard. Apart from the standard ASM monitors, arterial line invasive monitoring, you need a beat-to-beat monitoring. So that is a gold standard monitoring that you have to do. And central venous catheter, we need it because of all the infusions that we are going to give, and anticipating blood loss, because most of these tumors, in case they are metastasizing or locally invasive, they have a lot of revascularization and they bleed a lot. That is also there. And apart from, I think she has mentioned most of them. I don't, yes, in case the patient has any cardiomyopathy, which is very commonly seen these patients, pre-operatively, Dr. Anuja, you said that echo may be done, but I would again differ with you here that in 100% of the patients who come to you with a suspected pheochromocytoma, you should go for a 2D echo, because over time, because of the catecholamine induced stress, the heart undergoes a lot of changes, and either they land up into a dilated cardiomyopathy, which is also known as the Takotsubo cardiomyopathy, or any other changes. So intraoperatively, in case you know and you have the TE probe, you should go for it. So the transesophageal echocardiography should also be a gold standard in patients who already have a deranged heart function.
So what's your take on this, Vala, sir?
Yeah, I think what Dr. Asthana mentions is a very important point. I mean, so far we have left echocardiography as an domain of cardiologists, but TE can be very useful in this case, as we are producing more and more anesthesiologists who are comfortable with using a TE, and more institutes who are getting a TE. TE not only tells about the cardiac condition, but you are left with no guesses regarding the filling pressures. Like, I mean, CVP is quite, not very useful. And the thing we can use an advanced pleth waveform analysis like flow track or something, get a cardiac output, but then cardiac output is an incomplete thing. We if we have an TE probe, which does not cost anything, and it just needs our expertise to learn and use it. So TE can be extremely useful. And as far as analgesia is concerned, I usually, if it's an open surgery, then obviously an epidural, and start it late and the benefit is that you can continue it for several days. And if it's a laparoscopic surgery, I would just use a NSAID combination. NSAID is if the kidney renal function is all right, and then go for morphine and fentanyl PCA. I think that should cover, because in case of laparoscopic surgeries, the pain duration of pain is very less. The initial 6 to 8, maybe 10 hours, the patient is in significant pain. Then the requirement of analgesia is quite less, can be easily managed.
All right.
Dr. Abhijit, I just want to add one point.
Please.
Although everything has been covered, but in the post-operative period, actually, that profound hypotension, the drugs which we were using intraoperatively, the adrenaline, noradrenaline, may become useless because of the extreme blunting of the receptors. Therefore, the only way sometimes to recover from that severe hypotension is to use direct vasopressors in the form of vasopressin. So that is one important thing we have to remember, that this is a very common thing in the post-operative period. Nothing works to handle that hypotension. So that also has to be kept in mind.
So basically, there are 3 systems in the body which controls blood pressure. One is renin-angiotensin. The other is the adrenergic system. So renin-angiotensin system we cannot manipulate in such a scenario. And the adrenergic system, like it's totally unpredictable in a way, that because there is so much of blockade. So vasopressin is the only one that you're left with. So in case of any other scenarios also where the hypotension is resistant to adrenergic agonists, and we are fairly certain that there is no significant hypovolemia, then obviously vasopressin can be tried. It's also quite easy to administer.
I wish someday we have a simulator that can, train us for upcoming cases of pheochromocytoma. We have AI integration in a simulator who can, give us the real feel of what it looks like to manage a pheochromocytoma patient. So we have some more seniors and experts in our audience pool. If anybody wants to share some clinical insight and expert opinion, feel free to do so. So if I look at the attendees, we have definitely the Honorary Secretary of ISA Delhi, Dr. Amit sir. Sir, if you, and congratulations if you want to share some clinical insight on this.
Thank you so much, Dr. Abhijit. I really want to congratulate Team RSA West Bengal that for a very crisp unity and diversity kind of a topic. And this is there. Just want to clarify in between that earlier we were RSACP, now we are RSA only. Right? This is there. The clinical pharmacology has been removed from the name and just from the society side. Right. And as far as I remember, long back, if you remember, Dr. Abhijit, we have done a good pheochromocytoma case long back when you were at Maulana Azhar Medical College. And we had many sweet memories of that particular case. The topic has been dealt very, very nicely. Yes, it has been rightly said that when you're dealing with that particular case, right, the infusion pumps are like keyboards. Right, this is there. Sometimes you have to press a up button. Sometimes you have to press a down button. Right, you have to be very, very vigilant about this particular thing. Right, one discussion I was listening about getting a TE done, as there are many postgraduates with us today. Right, this is there certainly at higher centers the expertise and the availability is there. But when in these webinars, our postgraduates hear about it, and when they discuss the case in their Viva OCs and all those stuff, sometimes they speak up about TE at the first investigation, right? Considering that it has been discussed in some of the webinars, right? So if you don't have any expertise about it, a preoperative transthoracic echocardiography is a norm. If your center has it, you are very, very have an expertise in TE intraoperatively for such cases. Yes, speak up about it. But just you have listened it somewhere, right? And to complete the list, don't speak up in your examinations. This is for the postgraduates, right? And this is there just because you have listened to this particular thing. You have non-invasive, monitoring systems, right, interoperatively for finding out the hemodynamic instability, the fluid responsiveness, and everything. So those can easily be done. Rest about post-operative analgesia, very, very beautifully covered. These days, lot many people are going for QL blocks in such particular cases. So that's all from my side.
Thank you so much, sir. Swati ma'am, if you can hear us and say a few words on this topic, maybe.
Yeah, I would say excellent selection of topics and covering them so well. Congratulations to all the speakers, chairpersons, and the moderator. So my area of expertise, interest was the neuromonitoring. So I would like to comment on that. Congratulations to the speaker first. Very nicely covered, touched upon every aspect of neuromonitoring there. And I think further each topic is a topic for whole day discussion. But he is using diagrams, very well explained the concept and the idea about each neuromonitoring device and where to use what. One thing which has to be understood is that no single monitoring is enough to know more about what's happening inside the patient's brain, but using multimodal, of course, as he has emphasized, and also to take that in consideration with the neurological assessment. The clinical assessment should not go anywhere because ultimately these are all monitors, and we have to work with them to know about a situation and then also to give treatment accordingly, not forgetting the clinical neurological assessment. So that's all from my side. Congratulations once again. Thank you.
Thank you so much, madam. We also have a very renowned senior from West Bengal with us, Dr. Tulsidas sir. Sir, if you can say a few words on these two topics. If you can hear us, if you're with us. I just saw you in the attendee list, sir. Are you with us? All right, I think sir can't hear us. So thank you so much, speakers, Dr. Anuja and Dr. Stranjoy. Thank you for sticking to your allotted time and finishing it, covering it all through. And for those postgraduates who have attended, that's the way how to cover the whole topic in a short span of time. And I would like to once again express my gratitude, and on behalf of RSA, express my gratitude and thanks to chairpersons Dr. Anju Madam, Shubhajit Pala sir, and Dr. Mati Madam for sparing your time in the evening and joining us and sharing your clinical insight with the attendees. This is being recorded and this would be in RSA's YouTube channel as well. Please feel free to share it with your fellow juniors and residents. I think both of the speakers did their share justice with the presentation, so that maybe the presentation might come handy to them at some point of time. So lastly, if Naveen sir is still in the attendee list, if he can hear us, Naveen sir, if you are with us, just I wish we can hear you for a few words from you. Vishal sir, is Naveen sir with us? Dr. Vishal?
I think sir is a little busy with some another webinar, and maybe he'll join.
I think we are almost done, sir. So in that case, once again, thank you to Naveen sir and you for giving us the opportunity. And in future, we would like to conduct more such academic webinars. And thank you once again, RSA, for giving us the opportunity. And thank you once again, chairpersons and speakers and attendees and those who have been watching for last 1.5 hours. Thank you so much. Any closing remark from you, Vishal sir?
Thank you very much. It was a great webinar. And when you said the top theme of the topic is unity in diversity, I was a bit confused. But the way the topics have been dealt, it has been dealt in so much detail and completely. Then I understand that it has all the fields have been dealt. Thank you to all the faculty members, all the audiences, and the chairpersons for holding such a beautiful webinar. Pheochromocytoma topic is always a tricky one, and neuromonitoring is always great. Thank you very much. Long live RSACP. Looking forward to see you all in RSACP Con 2027, Lucknow, April 2027. Thank you very much. Good night and long live RSA.
Thank you so much. Good night, sir. Definitely long live RSA. So this webinar is now formally closed. Thank you everyone for joining in, and good.
Thank you.